and get started as we allow the participants to continue to log in. You are joining the ADHD, anxiety, and depression. Many moods can mimic ADHD and requires a different treatment approach. I'm sure many conversations that so many of us as parents have had over the years. I'm Tiffany Feingold, co-founder of Guiding Bright Minds. I'm so excited. We launched about 15 months ago, and we've been doing 2 free parent webinars a month since we launched. My husband grew up with undiagnosed ADHD and dyslexia, so he knows firsthand what that experience is like, going through school and being misunderstood. And his path and his journey of his experience led him to start a company called Results Learning that focuses on executive functioning and focuses on academic coaching for kids. Then we have a son, and it was through that experience with our son early on with what he was going through with ADHD, with sensory processing, that led us to create Guiding Bright Minds. I was working in corporate America. I was working long hours. I was getting calls daily from the school about this and that. And it was overwhelming. It was exhausting. And I didn't know where to go, where to turn to. So we really wanted to create a hub for parents that really focuses on guiding you through this journey. We want Guiding Bright Minds to be a place where you can come to find out, to get more education on tools and resources, to get connected with professionals who are vetted and who are dedicated, like Dr. Kotler, to helping our neurodiverse children. You can go and research online and look up psychologists. There's 100 listed. So it's hard to find out who, what, where, and why. So we wanted to create a place that makes it easy for you and to unite you with other parents who experience the same thing, other caregivers, other professionals. Really build a community that supports and celebrates our children, focusing on their strengths, understanding their needs, and really solving what is best interest for them to live their life to their fullest, to thrive in everything that they do, and to be accepted exactly the way they are. So if you haven't gone to Guiding Bright Minds, if you haven't joined as a free parent member, please do so. I'll add a link into the chat so you can take a look at who we are. And I always say, I want feedback. I want to help you on your journey. What are you looking for? What are the tools and resources that you need? What are topics you'd like us to cover? Please let me know. I'll be happy to get that out there. I have created a couple new programs that help unite parents. First one is Birthday Buddies. It is on Facebook. I will add a link to that. It's just getting started, but what it does is it helps connect parents. We know that a lot of times our kiddos, unfortunately, don't have kids show up for their birthday parties. I want to stop that from happening. So how do we connect together as parents? And I also just launched, and last night was actually our second kickoff for Champions Together. It's a Zoom call for parents where we just get together and share, to let us know we're not alone, to help be able to meet with other people who understand what we're going through. So I'll send out more information. If you join us as a member, I'll also provide that as well. So let me go ahead and introduce Dr. Caroline Kotler. I'm so excited for this conversation and to have her here with us tonight. After 18 successful, fulfilling years in private practice, Dr. Kotler moved with her family to Colorado in 2017. Since arriving in Colorado, she has worked for both nonprofit and private organizations, most recently with pediatrics at the Meadows in Castle Rock. With much love for and support in the early 2020, she left to open Links Pediatric and Adolescent Behavioral Health. Dr. Kotler is very excited to finally be devoting all her time and focus as a behavioral specialist, where she knows her new community will benefit from her unique skill set and approach. Dr. Kotler attended medical school at Rowan School of Osteopathic Medicine in Stamford, New Jersey, graduating in 1994. After medical school, she completed her osteopathic pediatric internship at Kennedy Memorial Hospital, University Medical Center, followed by her 3-year allopathic pediatric residency at Cooper University Hospital in Camden, New Jersey. So without further ado, Dr. Kotler, I'm going to hand it over to you to go ahead and get started. Before I do, there is on the bottom of your screen, you'll see a Q&A. So all the participants, as we're going through the presentation and we get questions, please type your questions in that Q&A section at the bottom, and we'll allow it time at the end. So Dr. Kotler, over to you.
Thank you so much, Tiffany. I just want to thank you for this wonderful opportunity, first of all. Really is a privilege for me to be here. And I have to say that everyone on the providers, doctors, and therapists and staff that are on Guiding Bright Minds really are wonderful. They have, when Tiffany says she's vetted them, that is very true. We've met before I was invited onto the site personally a couple times in my office and came to me through someone else, and the chain continues. So I'm really, truly grateful for that and to have this opportunity. As Tiffany also said, I was born and raised in New Jersey. I've been here for 4 years now, so I still have that very East Coast thing going on. I talk really quickly. So I tell my patients I talk quickly, but listen slowly, and I repeat, repeat, repeat. So as you ask questions as I go on, by all means, or if there's a topic, because I could talk all day. I'm passionate, and I'm going to skim on a lot of these topics, but I could get in deeply. So if there's a question you want me to expand on one or head to tone with you, by all means, when I finish, we'll go into that. Also, a little bit about my personal journey. I have 3 children, and my oldest son, who's 24, is ADHD, bipolar disorder, and every acronym you can think of. So my journey really started off early, and my career shifted, and I worked into the advocate I wished I had had, trying to get all services kind of in one spot. And I can go on about that afterward as well, but I want to get going here a little bit too. So let's begin here. So I like to say all that walk, talks, and quacks like ADD, ADHD might not truly be what I've come to call neurochemical ADD. That's kind of my term for, is there a deficit of dopamine in the frontal cortex or not? And in the end of the day, that really is what defines true ADD, ADHD and how we treat it. And the treatment, as you all know, is with stimulants, and stimulants actually replace and put dopamine right here, back in that frontal cortex. And you're familiar with Adderall, Ritalin, Vyvanse, to name a few. And that part of the brain, the frontal cortex, is responsible for working memory, ability to focus, impulse control, attention, and oftentimes hyperactivity. That said, many other mood disorders can mimic ADD, ADHD. Back to the neurochemical versus non-neurochemical, meaning, is there that deficit again, or is there not? And will that brain respond to stimulants? And much can be learned by responses and to medications and failures. I'll talk about that more in a second. This doesn't mean that a child or an adult who doesn't have the diagnosis of ADHD might still not respond, but it refers to how we approach treatment. What does that mean? Different parts of the brain are affected, and different parts of the brain can affect how we focus, pay attention, and walk, talk, and quack exactly like ADD does. And before I dive into other moves, let me just say, first of all, that 2/3 of children and adults with ADHD have comorbid disorders like depression, anxiety, learning disorders, bipolar disorder, to name a few. And it's more the norm, not the exception. So you're waiting for it, you're looking for it. Plus, depression and anxiety, I like to call bedfellows. I like that word so much more than comorbid disorders, because to me, comorbid just sounds like death. And bedfellows means they're just kind of together, spooning, snuggling, just waiting to kind of rear their head and kind of give you a hello, I'm here. Plus, when children go through puberty and hormones rise and enter the brain, they're not the cause of problems, but they will definitely piggyback existing issues. So again, you're waiting for the child with just a little ADD, ADHD, they exist, there are a few, to kind of come forward and show you these other mood issues. So what mood disorders am I talking about? I'll start with anxiety. And again, I'm going to skim a little bit on these topics. I could go much deeper, but children, adults, and teens, with anxiety, the feeling when you're overcome, that butterfly in your stomach, that flight or fight, noradrenaline rush, it makes it very difficult to sit still, to focus, to pay attention. You feel like you want to jump out of your skin. So you can imagine it's difficult, especially for younger children, to kind of keep it together and not look like they are, raging ADHD. And when I say ADHD, just to clarify, we like to assume all know, but there's the inattentive type and the type with hyperactivity. And I'm primarily referring to the type with hyperactivity with this, because that's the one that people can see the most. You know, oh, that child's hyper, they can't sit still. But you often miss the child who's inattentive and well-behaved. I'm talking about the more obvious one for all intents and purposes here. And true ADHD, the hyperness, what we think about, I think we think about on a scale of 1 to 10, we think of the 50, but really the scale of 1 to 10, the true hyperness sometimes doesn't register. You know, it's not the kid who's running circles around circle time in kindergarten, or taking the water bottle and throwing it upwards, crinkling, 2 feet in the air, or, literally falling out of their chair, walking around the room. It's more the child who interrupts, the hand and the mouth go up at the same time. They're the chatty Cathy. They might tell some jokes. They're picking at a string, underpants, looking out the window, need to be redirected. They're not really that disruptive in the classroom. It's not the intense level that we, tend to think of. Older teens and adults with anxiety often just have a little bit of what's called psychomotor agitation going on. A leg is swinging or bouncing. They'll struggle to sit through a movie or dinner with their spouse, even a long conversation. You can just tell they've lost it. Their eyes, their gaze, they've moved on. They're kind of zoned out. It makes it, difficult for them to sustain that attention. And that's what tends to bring them, for help, their inability to focus. And older kids with this level of hyperactivity, the ones who are the 50, are the mood disordered children, the ones that have a lot more going on. And the same with the adult. If the adult looks like, the 5 to 10-year-old who's that hyper, think there's something else going on. My mother used to always say, 10,000 Frenchmen can't be wrong. I remember her saying this for a lot of my life, not many things. And I bring that back to, it's applicable when I take histories, meaning, a lot of times teenagers will come in at 16, like, I just can't focus. You don't just wake up, ADD at 16, it's something that's been with you from early childhood. I'm looking for themes throughout school where teachers will say, I got to bring Johnny back. I can't get his attention. He's all over the place, constantly forgetting the spelling list, the vocab list. Everything's online these days, so take that with a grain of salt. I'm going back to school for the textbook that you forgot. Older children and early teens, they'll leave, a jacket at the movie theater. They'll have a sleepover and they've left 10 items that are there. Adults, the keys, the wallet, that's obvious. But just forgetting, key details, or forgetting, an important something's on the calendar, for the children at school. So you're looking for this history that's gone through. When I don't get that history, I'm suspicious that other moods have stepped in that have now impeded this child's ability or adults to pay attention. The neurochemical ADHD, true looking child, that can be there as well. You can have two that overlap, but it's often not the presenting what I call monkey on the child's back. The bigger mood disorders need to be conquered first, and I'll circle back to that in a second. But what's often left is not a lot. Back to the anxiety and how it presents. I'll give you an example of a child. Oftentimes, and I'll ask children this question, and teenagers, think hard when you're sitting in class, when you're not paying attention. Is it more because you're in your head reprocessing, or is it really because you're just like, la, 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 what's a cute pair of shoes over there? What's happening with my cuticle? Ooh, the long guy out there, what's he doing? Or are you in your head looking what I call lights on, nobody home, that kind of 1,000-mile stare, not misbehaved, but they're in what I call reprocess still. They're thinking about all the woulda, coulda, shouldas, what happened last week, what happened 5 minutes ago, what's going to happen an hour from now, what's going to happen next period, and worry about a math test, that's last period, what's going to happen this weekend with friends, will I be included? And often they might waste a whole half an hour deciding, thinking, reprocessing, chewing it 10 ways to China inside and out until they've kind of reprocessed to satisfaction. Then they'll kind of look back up and try and zone back into class, and they figure, well, I don't know what the hell's going on, so now I'll just kill the last 10 minutes. Then they'll start picking with that string, doodling, picking at the cuticle. That's when they'll look distracted, and a teacher might make a comment, they look distracted. So it's this very muddied water picture, but if you really tease out kind of what came first, often, children, teens will give you a very, they'll walk you down a very path that makes sense of where this comes from. And again, this impedes their ability to learn. They're just not available. They're somewhere else in their own place. They're also often cranky, irritable, quick to snap, easily overwhelmed. They'll shut down on learning. Another example with anxiety, especially in childhood, is children will be an angel. They might be distracted at times in school, but they're never a behavior problem. In fact, the teacher wishes they could clone them, bring them home, best kid in the class. They're in shock to hear at a teacher conference that the same child who they think is an angel is having epic meltdowns at home, like epic on the floor, rolling, screaming, throwing things. They can get aggressive with family members. The meltdowns can last, sometimes for hours, and they're very difficult to manage. And homework is a hot mess of a nightmare. They just melt down and shut down at the thought of doing it. And at the 11th hour, at 9, 10 p.m., or they'll wake up early, they'll bang it out, they'll get it done, because the last thing they want to do is show up to school looking unprepared and having to face what I call the firing squad, because they care so much about what everyone else thinks. So that child will sit there dying, literally in their seat with a tornado brewing, but they'll look fine. And I often face this at IEP meetings when teachers will say, well, I can't see their anxiety. They look fine. They don't look anxious. And my answer is, you can't see the diabetic sitting in your class either. Sitting there with a sugar of 350, they're not feeling good. Their heart is palpitating. They're sweaty, but they look fine. And you really can't tell them apart. So, children who internalize their anxiety will die inside, and it has to come out somehow through irritable, cranky behavior or having these big meltdowns. Other children will externalize, and they will act out, shut down, crawl under the desk, make noises, deflect when they're overwhelmed, when work is too difficult. So again, two very different sides of the coin there. With depression as another mood, the executive functioning often tends to drop off. Children with depression don't have to look sad. In fact, the hallmarks are with depression are anger, irritability, and distractibility. They're not walking around saying, I'm sad, God forbid, I want to kill myself, crying all the time. So we don't perceive this as picking up depression. Well, I think my kid looks happy. They're just cranky, irritable, miserable, shutting down every 3 seconds, and, kind of hostile and angry, not even necessarily isolating. They like to share their miserableness with the rest of the family. But the executive functioning, the ability to future orient, to plan, falls off, and they don't care. And often they won't do homework and they won't bring it home, and grades drop because assignments are missing. And I'll ask these children, I'm never mad at them or upset. There's no judgment here. It's always sunshine, lollipops, and rainbows on my end. I'll ask them, did you truly forget? Like, you're at your locker, the bell's ringing, friends are talking to you. Did you forget to bring it home? Or were you looking at it thinking, close that locker, I'm just not doing it because I don't care? Or you bring it home and think, not happening. And these are children who do care. They want to get it done. They don't want to be embarrassed the following day. But even those feelings of guilt and anguish don't overcome the inability to put the pedal to the metal in the moment. They're just too overwhelmed, and just having them do homework and do the extra assignment is just too much. They just don't care and can't get over that hump. So then they look like, oh, well, he's lazy, he just forgot, when that's really not what's going on at all. Then there are other mood disorders. And when I say mood disorders, ADD is a mood disorder, for example, so is anxiety and depression. But I'm talking about the disrupted, dysregulated, irritable toddler who's melting down because her shoelaces aren't tied the right way, all the way through bipolar disorder, through even schizophrenia on the other end. And I always tell parents, this is a spectrum, right? You can have what I call toenail in the pool. I'm a very visual learner, so I like to give a lot of visual examples myself. Or you can be lying on the drain in the deep end, right? So just because, you might respond to a particular medication doesn't mean that label is so hardcore. It just means that you are off the grid of the garden variety types of depression and anxiety. So there's manic behavior, hypomanic behavior, and they look all the world like ADHD on steroids. It can be this can be a happy child who isn't irritable, cranky, angry. They're just a Tigger, either a Tigger, bouncy, or you're an Eeyore type of personality. And these children often come in having tried and failed many stimulants. And the reaction to those stimulants, which I'll get into a second, really is very telling. But this is the kid who's, what I call flight risk, really somewhat of a danger to themselves, taking off in the, parking lot of Target, climbing in the home, getting into things where they can truly be a danger to themselves. Like, you can't turn your head for 5 minutes because they're into something. They make epic messes. They go from one toy to another toy to another toy. It might be touchy-feely in your face, in your personal boundaries, all those types of behaviors. And again, you can also see with these children, quick shifts in mood. You know, adults and children act very differently, even older teens. And we think of mood disorders, again, we think of these epic, you know, fluctuations. I give the example of like Charlie Sheen, if y'all remember when he gave those interviews, you know, with his tiger DNA and Adonis blood. You know, we think of someone, you know, thinks for Superman, gambling all their money away, having sex with 10 strangers, then being under the covers, you know, for the next 2 weeks, being dark and suicidal. And that really isn't the case with younger children. You get a lot of, you know, ups and downs, silly, giddy, happy, all is well, 1 minute, then 20 minutes later, they're irritable, crying, upset, can't handle no, wanting 10 different things, and then seemingly fine the next minute. There's these very quick, rapid cycling mood shifts. And with that comes a lot of psychomotor restlessness, agitation, walking around, not knowing what to do with their bodies. You know, it makes it very difficult. The response, I guess I'll talk about that for a second, to stimulants is very telling in this population. When you miss the diagnosis, it's when a child can look like a zombie, right? That's every parent's biggest fear. Like, don't put my kid on this. I was given that, or my brother, and my kid was just this zombie, and I'm so scared of that. And that breaks my heart. So my answer to that response is always, well, then the diagnosis was missed. There was a bigger elephant that was being danced around that was missed. Because, you know, even if there is true neurochemical low frontal cortex dopamine would respond to a stimulant present, it's the least of their problems. The bigger monkeys on the back, when you're truly getting emailed, called from school, at risk of losing a job, teenagers, you know, failing grades, that's when, you know, it becomes more life interruptive. And often, you know, a stimulant is prescribed first. Let's talk about it. So what happens is dopamine, let's just start with this, is a mood stabilizer. Whatever your mood is, whether you're anxious, depressed, cycling, angry, irritable, can't focus, whatever it's doing, it will flatten it out for a period of time. But there's a price to pay when there is not low frontal cortex dopamine. And that is what I affectionately call, and I infuse a lot of humor, the snort cocaine effect, if you will, because you just get this stimulant effect. You will focus, you'll be less anxious, you won't be as irritable, but older kids will say they don't feel like themselves. Some younger kids have said to me, I'm talking at lunch, but I'm talking in my head, it's not coming out. Some children will tell me they don't feel creative, they don't want to take it on the weekend because it stumps their creativity if they like to write poetry or music. And that's just not the case when you hit the nail on the head. With true neurochemical ADHD, you can give a kid a boat ton of stimulant at bedtime, they'll go to sleep, they will eat. The children who the diagnosis is off, the witching hour, 4 to 6 p.m., you look at them cross-eyed, very emotional, teary. It's not until like 9 p.m. at night, they're kind of back to themselves again. And they kind of go through this almost looking manic, talking loudly, quickly, more ADHD than the kid you set out to treat in the morning. If you're requiring 2 doses of a long-acting stimulant, that's my favorite, to treat the ADHD, you don't need what I call an Uzi, when a BB gun will work, meaning the child who's on Adderall 20XR twice a day or gets a little Mickey at noon or 4 p.m. Because what happens is that dopamine is doing the heavy lifting of the mood stabilization. And once the dopamine level starts to drop, this rebound effect comes out, and you're having to slip it in again. And again, when you truly have true neurochemical ADHD managed well, the curve is seamless. You really can't tell when the child is getting the medication and when the medication is wearing off. For example, many patients' children, and parents think these children are stable and fine and doing well, wake up like crazy people all over the place, can't follow, you know, a 2-step command, let alone a 1, hyper all over the place till that drug gets in. 20, 30 minutes later, they're calm and they're good to go. That is a child who's not mood stable. There's another mood there because once the stimulant gets in, it starts doing the heavy lifting of the mood stabilization. When you have mood stabilization and you're treating the other underlying disorders, the mornings are smooth, your nights are smooth, bombs aren't going off. It's not unless or until you have a child do a higher cognitive task, like write a paper late at night, that you realize like they're just all over the place and they can't organize it, and they realize it as well. When a drug is a good fit and it feels good, kids will come to you and say, Where's my medicine? They'll poke you on a Saturday morning. It's 7 o'clock. Where's my medicine, Mom? It's time to take my medicine. When a drug is not a good fit and kids don't feel well, that's when they'll skip a dose. They don't really care about it because it's not benefiting them so much. So when there is versus isn't, back to the true neurochemical ADHD, I treat the bigger moods first, because what's left is often like this much. And parents are in shock that, oh my God, my kid is focused, I'm not getting emails, the behavior is beautiful, we're not even on a stimulant. How could that happen? And sometimes I might not even add it because it might not be as intense or life interruptive as they originally thought that it was. I'm gonna make sure I didn't skip any really good important things I wanted to talk to you about. One of the other, no, I think I did hit it there. One of the other things, I like to say is that, you can't talk to your pancreas, right? One of the reasons I also shifted into this area of focus in my career was, aside from my journey with my own son, was I really saw firsthand that, unlike older adults, we kind of roll our eyes, just get up, suck it up, feel good, feel better. What do you have to be anxious or sad about? When you see a child suffer and you see that these behaviors truly are out of their control and how sweet they are in these moments when you get to see the best of them, these glimmers, your heart aches when you see how kind of twisted and contorted they get when it's not in their control. So how can we make it better? And, these mental health issues, especially for children who lack the ability to articulate how they feel like older children do, just like diabetes or asthma, these are chronic, mental health conditions that need to be tended to over a lifetime. And we know from studies now that, the genetic component, I could talk all day, but, when nice big studies that have shown that when parents and grandparents have issues in the family, your child's going to have issues. The genetic piece, is definitely there. And to jump on it early. And we know also with these other mood issues that the earlier we treat and we take this type of mood to make it more stable, the better the future looks. And the more med susceptible they will be. Jumping in later at 20, even 15 to 20, trying to get that mood stabilization, you bang up against much more medication resistance, and it becomes much harder to stabilize. And we tend to have these, fears of like, I could send a parent home with 5 asthma medications, inhaled steroids, nasal steroids, Zyrtec crosses the brain, Singulair causes all kinds of mental health issues when they're there and crosses the brain. You have to know your patients, but they'll take it and won't ask one question. They'll do everything I say. If I say Prozac, oh my God, everybody starts to shake. Or if I say Ritalin, like, oh my God, no, not that. Or I want that Strattera medicine. I heard it's for ADHD, but it's not a stimulant, anything but. And my answer was arose by any other name. We're treating a disorder, whatever it takes, and getting over the fear of the names of medications. And included in that are antipsychotics. If I don't say it 10 times a day, that I hate it. It gets a bad rap. They don't call Prozac the crazy panic attack drug, right? But yet, antipsychotics, which are really just dopamine antagonists, like Prozac is a serotonin reuptake inhibitor. All they do is lower or antagonize dopamine midbrain. Sounds so much more pleasant. But the names of these drugs and combinations are scary. And when you look at the risk-benefit ratio, especially when you see TV commercials with tardive dyskinesia and you take this drug, you could die. You think, why would I ever, let alone take, many of them? And the answer is the quality of life for this patient population, just the trajectory just shifts unbelievably, especially for the autistic population. I'll give that a plug because they too are not immune. Almost every child on the spectrum has a boat ton of anxiety. And again, the availability for learning. And they look like, hyper crazy kids as well, that once you address that anxiety, they just kind of open up and what's inside comes out. The conversations sound more mature and the availability for learning is unbelievable. I'm a big fan of forget the bouncy balls, the strings, the tension things, and reduce the anxiety, allow them to transition, allow them to socialize to their best ability without crossing boundaries and being available to see all the verbal, nonverbal cues that go on, at lunch and recess, just opens up their future for them to feel normal. And the same with these mood disorder children, because, when you are born hardwired anxious or sad, one of the things that really gets me going is when parents say, even in consult, well, why are you anxious? Or what does he have to be sad about? My answer is he was born hardwired sad and anxious. That's what you don't understand. Nothing had to happen. And when I ask a child, a teen, do you feel anxious? I'll give you a little visual here. This is what I call my anxiety meter, right? And if here is 0, no anxiety, and here is the worst panic ever, for a child who's born here with decent anxiety, their life is lived here from anxiety all the time to full-on panic. They don't know what an anxiety-free life feels like. So to ask them that question is like asking someone who's blind to describe the colors of the rainbow to me. It's impossible. And when I ask, are you sad? Nope, it's all good, I'm fine. They don't know what feeling happy ever felt like. They've always been kind of, this down, just not that, I like to say, if I see gums and porcelain bouncing down the steps in the morning, when I meet with depressed children, I can see it in 3 seconds, be it on telemedicine or in my waiting room. I'm like, oh, it's going to be a fun visit. Because I can just tell, they're just down versus mood disordered children who kind of bounce. They're happy, great for a minute, then they're down, sad, suicidal, dark, and then, totally shift, not looking sad. So again, I'll start to wrap it up. I want to get to questions and give Tiffany a chance to jump in here. Obviously, I'm very passionate about this subject. My consults are 3 hours. I'll say on average, for those of you, anybody out there who's a patient who's been with me, they usually sometimes will go a little longer. It's what it takes because it's an in-depth, deep dive into not only observing the child, I don't care how young they are, I pick up so much from watching a child for 3+ hours, but the family dynamic, right? Because no matter how flat that pancake, there's always two sides. That child is not just, themselves individually, they're a piece of the whole, and that's the family dynamic. And that's, be it there's a divorce, got a death and illness in the family, a major move from one city during a critical age of development. There's so much going on, how the parents relate to each other, the parents are together. The family history is hugely important. It gives me insight into how the parent is parenting and functioning and approaching that child. And the mood of the parent, are they available to see and watch their own child? There are some parents of children that I've said, I want to help you, but I can't yet until you get help for yourself because you're not available. You have to be able to read your child's mood when they walk in the door so you don't become part of the problem. And when our moods I joke and say we open each other's lions cages and we're out rumbling, they tick us off, they know exactly what button to push. They'll say, I hate you, you're a rotten mother, then you start crying and they love that. They know exactly, these children are master manipulators, all of them. Normal children too. They've mastered their game very well. So they know exactly what to do. And there's many manipulative moments and very many mood-driven moments. So being able to see what's manipulative, intentional behavior, and what is uncontrollable, truly mood-driven moments really requires you to be present and available and stable in your moods as well. So I really dive into all of that, as well as the academics, understanding what they need, jumping in for advocacy. I attend IEP meetings, 504 meetings. I am the Crisis Hotline. I'm available 24/7, and it's not just propaganda. I truly, truly am. I answer questions all day long in real time and I felt it myself as a parent 20 years ago. When you prescribe a psychotropic medication, it's a big deal, and parents need to be a united front. And I like to partner with my parents. I want them to understand what the diagnosis is, what part of the brain I'm trying to treat, why I'm going there, what medications I'm using. Genetic testing is a wonderful tool that I'll employ often for my patients because every arsenal we have in modern medicine today, you deserve to have an option to look at, sift through. It's a launch pad. It's not everything. It's another piece of the puzzle. You have to take the clinical and see if the clinical matches the genetic as well as the response to tried and failed medications, which are always so sad, but they speak volumes. Every failure, we learn so much about that brain and what chemicals. So I really take a neuropharmacological approach as well as a deep dive into the clinical. And the relationships are my thing. Again, because if a child can't relate to you, I don't care if it's a therapist, a counselor, a physician, trained, handed down by God themselves, if they don't click with that family, with that patient, then you don't get the whole story. And the child, teen, adult won't tell you the nitty gritty. Or they'll text after and say, I really wasn't honest. I didn't tell you everything. I've had that happen too many times to count. But like I said, if we don't get into it and get all the way in, if they don't feel validated, understood, I say my office is a safe place for kids to be seen and heard, accepted and validated. And that's everything. They often just leave knowing that, my gosh, someone gets this. I'm not crazy. Often the genetic testing is validating when they see, oh, okay, like I'm hardwired this way. There's a reason for that. Okay, I get that. I'm not just, the this crazy struggling person making it all up. So I think I will end it with that, Tiffany, and let you turn to questions.
Oh, wonderful. That you're such a great conversation, such a great topic. I love every conversation I have with you because it actually, fortunately, answers a lot of questions, but also ignites many, many, many more because there's so much to learn. There's so much to understand. We have a lot of great comments. I'm actually pasting the link right now for everyone to Dr. Kotler's website. I know in there people are like asking about consultations, asking about everything, wanting to know more information. So I just added her link to that. When I send out a copy of the recording, I will include that as well and her contact information. So let's start, because I know there's been a lot of comments, a lot of questions, a lot of things going on. Yes.
I'd say also, if it's possible, Tiffany, to put the questions to your site, I'll come on your site and answer those questions as well, if it's easier.
Yes, I can definitely do that.
One place.
Yep. All right, so let's go ahead and get started. In the Q&A, kiddos who become agitated and, for lack of a word, mean when not taking their medication, does that indicate or refute neurochemical ADHD?
So when you say medication, I assume you mean the stimulant. And yes, often parents will be like, oh, this is amazing. It's great. They text me 3 days in. I'm like, well, the jury's still out. Text me like in 3.5, 4 weeks, because even though stimulants are, short acting, they're in for 10, 12 hours. There is a blood level that does build up. I could test a child's urine a month off of a stimulant and still pick up the traces of the metabolites. So yes, when they are angry, mean, again, the stimulant's doing the heavy lifting, and what you're getting back is a rebound, slightly worse version of the mood disordered child with inattention, hyperactivity that you set out to treat in the morning.
Okay. Any kid or any recommendation for kids who hold it together at school in advocating with schools? We have struggled with when giving him a heads up, and an agenda keeps home behaviors from escalating. It always becomes a battle because they don't see it.
I have several patients I'm managing right now that are, total hot mess. In fact, one I kept home from school last week to kind of do a reset and pull one medicine off and start another. And this is one of the reasons I attend IEP meetings. And often, my niche comes in where the child has a normal IQ, has normal achievement and academic scales. There's no learning disorder present, but yet they're failing, or in Colorado, it's IREDIs, CMAS, DIBELS, whatever the benchmarks are for reading math, they're below grade level consistently for several years, having to fight and say, the mood disorder impedes their ability to learn. It renders them unavailable. They need remediation by default. And under the IDEA, they're entitled to FAPE. And, when a diagnosis impedes a major life activity for a child, that's school. And I can prove that, this is it. And I go back and forth with them. And it's a process, right? So we often have to settle for, I reach for the sun and the moon first, I land on a star, I'll take the 504, and we just continue documenting. And when the child continues to fail, which sure as I'm sitting here, they will, and the mood disorder isn't stable. And listen, even with genetic testing, the best history, and even coming on, some tried and failed medication with even more insight, I tell parents it usually takes on average of 9 to 15 months to try and get to some place of stability. And for some families and children, it's a couple of years. I mean, I won't tell you how many years it was for myself. And that was with, the top specialists that the country had to offer, because I literally flew all over the country seeking out the best care that I could to have better understanding. It is a process, and tomorrow's not coming. When a child, the earliest signs of anxiety are separation. And that's at night with sleep. Like I said, I could go on to 10 different topics, but it's also with being dropped off at preschool daycare, or any stranger for that matter. And when you struggle so deeply in pre-K, kindergarten, tomorrow's not coming. Life goes like this, right? Every transition to middle school, high school, college life just opens up more stress emotionally, socially, academically, and anxiety is cumulative. I'll explain that. It means that, a little thing can happen in a child's life, in a child's day, and it's not such a big deal. So we're like, suck it up, buttercup, move on. It's not such a big deal. But, each little hit event that happens becomes their new normal. You don't go back to baseline. And when you're building this intricate house of cards, literally on their back, one little card just brings the whole house down. like one little breath, they fall off that cliff. So, it's all these hits over the years that it becomes very difficult. And conveying this to school, it's like the child who jumps off, teen, young adult, who goes off to Harvard, who jumps off, straight A's, perfect SAT score until they jump off the dorm and commit suicide. They're great until they're not. The whole house literally comes crashing down. The group that you're talking about are the type A personality perfectionists. Nothing is good enough. A lot of negative self-talk. They'll sit dying inside. They'll never advocate. They don't want to look different. They have intrusive thoughts of they're looking at me thinking I'm stupid if I raise my hand. They're going to think my answer is silly. If I'm walking down the hall, they think I'm ugly, I'm hideous, I'm not worthy. And they just try and keep this together. And that's the child that comes home and just melts and loses it. There's just such intense social anxiety and this fear of, persecution, judgment, failing when the only one that they risk failing is themselves. I tell these kids the only thing they hate is yesterday and tomorrow, because they can't control on what's around the corner. And all we can control is, right here in this now. But those children are really anxiety on steroids. They come home, they get in the car and they just lose it and start kicking the back of the seat and kicking their sibling and meltdowns and won't do homework, but somehow we'll get it done by the next day, whether, parents battle all night to do it. But, there is some control there, I will say. The children who, and I have this discussion with kids, the child who, they're very mood disordered, more on the disruptive, dysregulated side child who will take their shtick into school. If you have that meltdown and you're rolling around the floor in 4th grade, you got a real mood disorder. You're doing it at school, which means these blinders are on because every child wants to be accepted by their peers. But when they are so emotionally driven that they just lose it and the blinders are on, that they forget the world is watching and formulating opinions and taking steps back, thinking they're awkward or weird, they literally can't control that. Where the child who's melting after school and holds it all in, there is a degree of control. And I say to children, I will never tell you how to feel. You can hate your mother, you can hate me, you can hate the world, you can hate math, but I will tell you, you can't destroy property and you got to keep your hands to yourself, because that you can control in school. When the tornado is brewing, you can control it at the mall. You never lose it, never let anyone see you sweat, maybe 1 or 2 close relatives, that's it. But there's a lot of behavioral discussions that go on in that situation with the parents and how to manage, because again, you can't talk to your pancreas. When a child's mood goes from 0 to 60 in 5 seconds, you can't stop to apply strategies learned in therapy. And especially the younger ones, if it comes down to the parents, how do we manage them? How do we not make things worse? And how do we teach them that there's some level of control, that you can't just come at me, hit me, beat me up, hit your sibling, push them to the ground, that there is a level of, behavioral control that I expect. So that's where I work with families and parents and children, get them to understand where they have control, where they don't, and the parents as well. I hope that helped.
Wonderful. And the questions are rolling in. I think we have 15 in the Q&A and several more in the chat as well. How can we help our kids when they have major meltdowns and sometimes to the point of hitting and throwing things?
That's, like I said, that's, and I thought I had a patient in my office yesterday, this sweetheart, the one I kept home, and she lost it. And the mom said, do you even remember saying this or doing that? And she's like, I don't. And these children don't. They're such a high cortisol stress level. That's the stress hormone that kicks off the whole flight or fight cascade. They don't. Again, it's these blinders. They don't even know what's coming out of their mouth. And when you're in this, I call it getting emotionally flooded. When the whole flight or fight reaction takes off, they're so flooded. Whatever you're saying is like, want, right? Like Snoopy and the Peanuts gang. They're not hearing a thing. So when we try and discipline them at these moments and say, don't do this, do that, think of it, they're not getting any of it. The best thing to do in that moment is just step back, which is the hardest thing to do, because you want to hang them out by their left toe in that moment. Take a step back and just say, I love you. Let's hit the reset button, forget the rest, be your best. You want to hug, but don't escalate with them. Don't get on the roller coaster. That's my number one piece of advice. Just let them pass. Don't get a ticket. Do not hop on the roller coaster. A patient of mine said to me, I'll date myself here. There was a comedian by the name of John Gallagher. His last name was Gallagher. Had bald, long hair, blue and white stripes. And he, at the end of his routine, he would smash watermelons. And he would give all the parents in the first couple rows, rain slickers and the science glasses. And one mom said to me, she's smashing watermelons, and I just got my raincoat on like I'm at a Gallagher concert, put the goggles on and just sit there, wait till it's over and then take it off. And I was like, props to you, because it's not about you. When you start to cry and get sucked in and, oh, she hates me, I'm the worst one in the world, I'm like, good, I'm doing a good job. I'm sorry you feel that way. I never stop loving you, and move on. I'm sorry you feel that way. I never stop loving you. Forget the rest, be your best, and move on. It's very tough. I've been through those moments. I've lived them. And when you try and conquer a mood disordered child, that's your first mistake. You learn it by default, of course, but you cannot be, traditional behavioral modifications do not work with this population, period, end of story. You can't, the negative consequences, taking things away just escalates, end up calling police by the time they become teenagers. And I've been there too. Positive reinforcement and catching it before. Like, for example, the functional behavioral assessment, right? Many of you know what that is. It leads to the BIP. I read one last week and I was like, oh my God, when he's rolling and screaming on the floor, we'll do this. And I'm thinking, why do we have to get to rolling to screaming on the floor? Why don't we notice the dysregulating triggers and not let him fall into the hole, and let's walk around it? Because, if you give a kid who gets easily overwhelmed and will shut down with, a writing project, for example, or you give them a sheet with 10 math problems, it's like, oh, word problems, forget it. It just looks too much writing. I can't do it. They'll shut down. Let's just give a problem at a time. Present one problem on a page. Don't even adjust or modify the curriculum. Just chunk it down in a real way. That's great. Now let's get the next one. That's great. Or see that Johnny's having a hard day and just, let's tuck it in your notebook and let's just bring it home. Or when a child is struggling, don't push. When teachers push and try and strong arm, that's when it kind of all unravels. That's another topic. I'll move on to the next question for you, Tiffany, because it might come up.
All right. Can a child develop a new mood disorder over time? For example, initially have ADHD and anxiety, but then develop depression, etc. later on in life? How can you tell that the additional mood disorder is there? They all have similar symptoms.
That's it. Bingo, hit the nail on the head. My response is the mood disorder was there the entire time. And there might be ADHD or not. I don't care. It's what I go after last, because you don't want to overtreat it, number one. And you want, my mantra is always start low, go slow, and one drug at a time. We want to fix it yesterday. And believe me, I want to reach in that black bag and pull that, dart and throw it and have it be a winner. But the ADHD that you see is more likely hypomanic or manic behavior and huge anxiety. And again, just the irritability. You're not looking for depression in the traditional way, but I will argue the depression is there in those moments of irritability, distractibility, anger. And then it often isn't until later teens. Listen, I've had many patients who, raging ADHD and anxiety, insecurity, wasn't until I got to college, the first true depressive, I can't get out of the covers, I'm skipping classes, help me, started to come out. So it was there. I joke, there shouldn't really be any adult psychiatrists. They should all be pediatric, because you don't wake up at 20, 35, 40 with a problem. It was there. What was the stressor? Like, listen, who's normal, right? None of us. We all got problems. Certainly part of the gang. My children do not, fall off the apple cart. But where does it become life interrupted is where I come in. And it isn't until academic failure sets in for the adolescent. And, being intelligent is a gift and a curse. The truly, gifted and talented population, it's a problem because they can not pay attention, be distracted, even be the behavior problem, but they're passing straight A's. These kids are often smarter than the teachers. They know the spelling list. They don't have to study it. They can forget the vocab list. They know what the words mean. Oftentimes they're avid readers, even though they refuse to write, and they fly right through. It's the kids who are average to below, who, if they don't get the instruction, they're missing it. These kids don't turn in assignments. They don't have to in elementary school. They pass. It isn't until middle school, high school comes that the assignments start to bring the grades down. The parents like, wait a minute, my gifted and talented straight A kid all of a sudden has C's and D's. What's going on? And it's what's going on is it's been there the entire time. And the added stress, social, emotional, academic, the sex, drugs, rock and roll, of high school become a big deal and start to suck them down and intensify moves that were already there.
And I think this kind of aligns. What should parents do when kids develop anxiety, then depression, and get easily labeled, since it is very common, but providers don't look for the reason? Like any neurodiversity, and the kid will grow up with a psychiatric label, fail at school, and progress to more mood disorders. That happened to my son. His NVLD was not diagnosed, and he had been suffering from all those labels and drug for long until I could get the result.
So that's heartbreaking to me. And that's one of the reasons that, I shifted my life into doing this, because I felt that parents weren't being seen and heard. And even I listen, being in Southern New Jersey, I was 25 minutes outside of Philadelphia with the best children's hospitals in the country. I had children's hospitals 20 minutes, St. Christopher's Hospital, AI DuPont, and Cooper, where I trained. So I could cherry pick, the best of the best for whatever subspecialty I needed. And it was my turn. And I'd known them through my training and through my early years of practice. I was patronized. I was given pats, maybe some drugs for mom. One said to me, I was like, oh, never. And I'm never referring to you again, because I knew something was wrong with my son. And I knew that I was right. And I was lucky enough to have that knowledge and information and to seek out people to get to the answers that I want, because 20 years ago, we didn't talk about bipolar disorder and real true mood disorders in children. It was just being defined. And I was blessed to be with the mood disorder specialist in the country at the time who was doing the studies, who was, happened to be at Children's of Philadelphia and took my child on because he was that sick. And if I didn't have my son, treated at age 5, he'd be in an institution throwing chairs at someone, to be honest with you. And he would not have graduated high school had I not jumped in and done all that I had done, which took fighting with the district, going through full due process. So I got a very hard, fast, lesson, because the school districts, and I mean no disrespect to any school districts people here, but they will rape and maim you and they prey on your ignorance. And the last thing they want to do is open their wallet and spend money on you, like any insurance company, right? In your house, you have a flood, they don't want to pay to fix the damage. They want to do the minimal. And they don't know, they don't have medical knowledge. And one of my things I go meeting to meeting saying is, you're not a clinician, so stop making clinical decisions. When I battle back and forth of, for example, well, he has autism, but it's not, what's medical autism isn't, necessarily affecting his education. And I'm thinking, are you crazy? How could it not? Here's a child who can't communicate effectively. And the low-lying fruit, the level 2, 3s, they're no brainers, but the level 1s often aren't picked up until adolescence, when they just can't, the reciprocity of speech and really keeping those conversations going with teenage friends requires so much more to sustain it. It gets missed. And their rubrics, their measurements, and they say to me, well, what scales or screens have you done? And my answer is this: all my years of cognitive training, and I follow the DSM-5 criteria. And when a child meets it, and you're sitting there as a specialist, it's incredibly frustrating to be told, well, we don't think it affects his learning. And I'm sitting there going, well, you don't understand. You're not the clinician. You don't understand the scope and depth of this. And label schmabel. I never give up on a child. I don't give up hopes and dreams. I don't believe in brick walls. In fact, I'll slam into them or dig under, bust through it, let others push my tushy up and over, but I won't back up. I tell parents, we have speed bumps, detours, but if we want that prize, we'll get it. And if the goal is to have your child attend college, it might not be traditional. We might do community college for 2 years. Let's get through that with a part-time job and part-time classes. And I don't care if we major in registration for a couple extra years, especially for this group who's emotional and social, any mood disorder, including ADHD. Studies have shown emotionally, socially, they function 3 to 4 years below their peers. So you're asking, a 14-year-old starting high school, thinking about future, an 18-year-old who's really thinking like a 14-year-old, or 14-year-old still thinking like a 10, 11-year-old. It just takes time, and we just adjust our hopes and dreams and how we're going to get there. But with the right treatment and understanding, with the right professionals who are seeing you. Listen, I've always told parents, anybody going to your doctor, if you're not seen and heard, run, leave. I don't care how good they are. If they're not hearing you and listening, because that's 99% of the diagnosis all the time, be it medical or behavioral. It is getting all scopes and all sides, and it comes out and evolves as you get to know them. And that takes time, and having someone that you can come back to that's kind of holding the reins, that understands. Listen, one of my biggest beefs, and I mean no disrespect to any therapist, I hope this comes out the right way. My children have been in therapy for many, many years and continue to. But back to talking to your pancreas. A good therapist will recognize that I've taken this child or adult as far as I can. There's a real medical issue here to treat. I need to count on my other colleagues to diagnose, and let's work collaboratively, because even if therapy is covered by insurance, you're spinning your wheels and your time is valuable, because it's going, when you're not available and your mood's not stable, the therapy just goes over. Even my own daughter, for example, would tell me after a session, that was really great, Mom. She had some great ideas. I'm like, yeah, tell me. She's like, I'd love to. I don't remember anything. I just remember thinking at the moment, that sounds good, and then the thought's gone. They can't retain it, and they can't apply those strategies because they're still too anxious to even be fully present during a therapy session. So it really takes getting that child's mood stable, understanding, is it trauma therapy that we need? Is it, DBT, the dialectical behavioral? Is it CBT, the cognitive behavioral? Is it art, play therapy, whichever? I'll decide. I'll send to people like Tiffany, refer, consult, get those highly, capable, well-vetted group of people and let you get your bang for the buck, especially if you're paying for the service, because you deserve that. And the timing is right for the child to benefit from it. Listen, this isn't easy. There's no easy way. I wish to answer these questions. I hope I'm hitting enough of.
Thank you. Yes. One of them, and a big one, how does my child deal with bullies because of their condition? Which I know is
if I say to kids who don't have to come beat up for you, I'll take them out. I have no tolerance for the bullying. And one of the things that I find that happens is the parents have no idea the bullying. And I really circle back to parents and say, you've got to contact the school, insist on a meeting with the principal, the school psychologist or counselor, and that child's parents with you. They've got to be made aware of what that child's doing on a daily basis. It's not enough to bring a kid in and reprimand them somehow in school if they do that, and then send them home and the parent has no idea, and the cycle continues. And I don't believe that the teachers don't see it or hear it, because they absolutely do. And when a child comes to you and says, this child's bullying me, believe them. And you don't have to hear a thing. It's a look, it's an eye roll, it's a sense, a vibe that you are less than worthy, not important, stupid, not included, ugly, whatever it is. And it's soul crushing. And again, we know those studies are enough, forget the genetics and background, to cause and induce. And they stay with us for decades. And even, by the way, bullying within families. And let's talk on that for a second, because I hear and see such harsh bullying. I have my whole career, with siblings. Hate's a bad word in my house, in my office, so is stupid, because they just, that it twists that knife. And for many children with anxiety, what they're told, what they hear becomes who they are. Those words stay on their heart for decades. And I want it dealt with aggressively, quickly. And I also insist that, in addition to the parents of the bully being made aware why the child of being bullied is there, that the guidance counselor or counselor bring the two kids who are having issues. There's always a queen bee, right? Even if it's a group, there's always one ringmaster that the other kids will follow, down to have some sessions to kind of talk it out and get over whatever's happening. I don't care that, I can't force every child to like every child, but I can force them to be respectful. And they don't have to be your best friend, but you have to be respectful. That means you can't, be so whispering, rolling your eyes, excluding them every 2 seconds. You have to be respectful. And I really do demand that. Once I have zero tolerance, I get aggressive. And I often refer schools back to their policies. It's difficult with charter schools. Charter schools and public schools, for all you out there, are kind of, the other thorn on my side. They're wonderful schools, don't get me wrong, but they're not wonderful for children, a neurodiverse child, or for a child who has an IEP that needs to be enforced, because they just don't. They outsource those people to come in to do the evaluations, where public schools are more likely to have a school psychologist full-time. And other resources. Or if a school has an affective needs class, they're bringing in more psychologists, and those psychologists will leak over to other situations when children are having problems, or the school staff, needs more expertise, help. They're there, they're in the building. It's much harder to have that happen when private schools say, well, we can't meet your needs, It's just not their jam. They teach, to the bell curve and the average, and moving, and they like their numbers of college acceptances. They don't really care about the outliers and those who learn differently.
So I know we're at 6:59. We have several questions. I've captured all of them. Let's go through a few more, if you're willing to stay on and kind of look through some of the questions. Okay, if ADHD was diagnosed first, then anxiety, how do you assess whether the stimulant and or non-stimulant are necessary?
So my style is, if I'm thinking both, again, I already said it, I leave the ADD, ADHD on the back burner. Trust me when I tell you, it is the least of your child's problems. The least. When you calm a lot of the hyper behavior by addressing the anxiety, what you're left with, you think, gosh, I wouldn't even classify that as hyperactivity if that was all I saw day to day, that there's some children, and again, when I do the genetic testing, there is a gene, it's called the catecholamine O transferase gene, or the COMT, COMT for short. And it literally looks at the enzyme activity. We all have an enzyme in the frontal cortex. That's the enzyme, the catecholamine O transferase, that's responsible for breaking down dopamine. That enzyme is either moving what I call the Goldilocks sweet spot, just right. It's moving, at warp speed, or it's moving like a snail. So when it's moving hyper fast, your brain makes dopamine and it's gone. It's gone. I tell kids, you think you're so dope, you're actually not so dope, you're on dopamine fumes. Or the enzyme is moving like an old lady, and the result is high frontal cortex dopamine. Those scenarios, whether you're deficient or too high, act the same. And children with high frontal cortex dopamine, raging anxiety, more at risk for mood disorders. And you give a kid a stimulant, they just fall apart. Those children have constant noise, static in their head all the time, walking through life. They'll describe it to you. And, on the flip side, the children with raging anxiety who truly are neurochemical deficient, I don't care. Again, the hyperactivity that you see is so off the charts, it's mood driven. And what's left is like this much, that I have a handful of kids and I'm like, I say to the parent, like, I don't even think we need to go there. Less is more. Why add more medication when you don't need it? I love drugs, don't get me wrong. And I love to prescribe what I call the Bentley of, the new ones, the hot toys at Christmas. The insurance companies want you to drive a Ford or a Chevy before they'll put you into the Bugatti, as my kids would say. But I want to go for those because there's a reason. Sometimes they're weight neutral. You can't commit a child to a brain glue, I call it, for, many years, like a diabetic and the insulin, if they're going to be picking up 20 pounds a year, which leads to many more comorbid disorders. You've got to be aware. Every patient in my practice gets height, weight, blood pressure. And I'm following that in growth curves if I need to, because again, there are times I myself would spend $500 an hour for a med check from these top amazing people, and no one was taking a blood pressure or weight. I was doing it. I was ordering labs, and that was frustrating to me. This is really affecting their health. Or I was contacting, if I saw a child on a well visit I hadn't seen for a year, contacting their doctor saying, so, Johnny gained 30 pounds this year. I have to rethink, and his triglycerides are in the 300s, like this can't continue. And if I recommended something more weight neutral, I'm not comfortable with that. And I say, well, get comfortable, because I'm not comfortable with the 16-year-old who's going to have bypass surgery at age 40 if we don't do something now. So I was the one kind of thinking on all the lanes, because the medical, and you can't just look at the mental health, because so many children have other comorbid disorders and disease, hypothyroidism, for example, Ehlers-Danlos, a connective tissue disorder that is known to cause other mental health disorders, fatigue, anxiety, trouble focusing, that one doesn't just exist in its own lane. So being able to take in that scope with, I felt like I was just kind of, holding the reins between each, and saying, don't therapy a mood disorder, or don't therapy a side effect of a drug I prescribed. If you're written a medication and you have this adverse effect and you continue in therapy, and now you're therapying a side effect, not a true mood disorder symptom, I should have known about that and let's stop the medication. So, I'm here to talk about, even 3 days into a medication, I'll pull a plug. Because even on a low dose that isn't therapeutic for the disorder I'm treating, at a low dose when I'm introducing it to the brain, if it's not going to be a good fit, you see it in the first week or two. But, I tell parents not to rethink it. I don't care if they text me, at 10 o'clock on a Saturday night, because you're looking at your kid going, could it be? Do I think? Don't question it. Reach out and have that answer, because it's that level of comfort and relationship that it takes to successfully address and treat this population. And I'm definitely a unicorn, I think, in how I do what I do, for sure. Because I just always found myself holding all the reins to everybody, and it got exhausting. My tipping point was at an IEP meeting myself with my son's psychiatrist, psychologist, educational attorney, adding up the money, and I was scripting them, telling them what to say, what to do, because I understood this game and how it should go. And I'm like, gosh, this is ridiculous. One person should be able to handle all that. So I'm not an attorney, but I've come to understand the legal rights, and I have relationships with attorneys, and I'll consult them. My families can consult them because I know I send them bigger cases, and I'll walk them up to mediation, and then I'll bow out and let my friends come in. But oftentimes there's very few I have to refer, to be honest with you, because I do tend to get to do a good place and kind of, play the game. That's a whole other conversation of how to get an IEP in warp speed if you play a game. It's a game of chicken, unfortunately. And the end game is to get the services for your child. And we do what we have to do. Sometimes it's on the sly. To have a child experience academic failure is soul crushing for many. And that breaks my heart. Why should a kid have to hit the wall to the district for them to finally move and do something when the child can't sustain any more failure? So it's us pumping them up saying, listen, Johnny, we love you, we adore you. And there's no punishment here, but don't do the homework, shut down in school, fail. So we can say, hey, this 504 plan doesn't work. Now your best of your best hasn't worked. Now what? Now what are you going to do? Or we have the IP, we're at the school and it's still not meeting our needs. Now what? Let's find another program that can do it. So you kind of have to beat them at their game, which sounds sad, because when you walk into those IEP meetings, the whole team knows the answers and what they will and will not offer. And then you're the one caught with your pants down. The parents are the only ones surprised or, learning things as they walk in. The whole team has decided. And too often the teachers have gotten so quiet, they're afraid of losing their jobs. Budgets are tight. I know where we are in Douglas County in Colorado, for example, the pay rates aren't as high as some of the other districts in the area, and they are deficient. For example, the Effective Needs Inside Skinny Information program for this area for middle school has 156 openings. They are full with like 20 kids on a waiting list. Well, either 20 kids have to move out of district between now and I think August 9th, when next year starts, the academic year, or decline it for some reason. So many kids will go without the programming that they need because it just isn't here, versus East Coast land where I come from, so populated with all kinds of schools and options. I find myself really at a loss here, banging my head against the wall because the resources I need just don't exist. And that's a whole other, situation. But you fight the fight. And if you fight the fight with an advocate who understands, and more than just the law of the school, when you understand how these mood disorders play out, because I sit there going, tomorrow's not coming. They say to me, well, you just started the medication. If you say ADHD, just start that stimulant and get back to us. You say mood disorder, it's like, listen, I'm trying to dance around the fact that this kid is going to be a mood disordered hot mess. This is what we see at 14. Where do you see what's coming at 25 if we don't get a hold here? And it's not as easy as, let's reconvene, in 6 weeks. No, let's reconvene in 5 years. I'm going to be playing, and this is just the start. Most kids take 3 or 4 medications if there's ADHD also that does need to be addressed, on top of, a seizure medicine, a mood stabilizer, and an antidepressant, anti-anxiety medication. And it takes time to layer them on to see exactly what you want to know, exactly what each drug does, what it does and doesn't cover, what the sweet spot is. You almost kind of want to go a step over to know that you're maximized. You don't want to be on a drug and do it kind of half-assed. You want to be fully, I want remission in my world, and I will die trying. I don't give up. I don't accept defeat. That's part of my issues. Like I tell my patients, I will die trying. I get just as passionate for my patients as I do for my own children, but you shouldn't have to. Would we accept defeat with cancer? Would we accept defeat with asthma? If your kid was on 2 medicines and couldn't breathe, like I tell parents, if you're diabetic, sugars of 200 are decent, but I want 100 all the time. I want tight control. I want those kidneys, eyes, toes, all present, working at 85 when you're a ripe old grandmother. I want it all. And why shouldn't we? And why shouldn't we be seen and heard? It's just a poorly identified area of medicine, sadly. And even those who are specialists in the field still have deficits. Listen, I have 20 years plus of general peds under my belt at the same time I was doing all of this, and a lot of what's normal. I know normal child development within 3 minutes when you walk into a room and see a child. You know what normal 3-year-old behavior is. You know what normal 5-year-olds sitting for vaccines, even for a child who's anxious, what normal 11-year-olds come in for vaccines, what a kid who's sick and cranky should look and feel like and tolerate, etc. That when you add mood issues to it, there's just much more insight than just, no disrespect to the whole psych world either, but it's just, I think the training needs to shift to a larger scope, because fun fact, primary care, which is OBGYN, family medicine, internal medicine, and pediatrics, gets a month in this area in our training, by the way, next to nothing. And it's a blow-off month for most people, residents who roll their eyes. They're pissed they have to go through it. It's not where they want to be. And, it's maybe a couple questions, on our boards, but yet here we are. We're 1 in 5. 1 in 5 doors I would knock on for, well, child check has a diagnosable treatable disorder, 1 in 5. And I can argue that's so much higher after COVID. It's ridiculous. But that was before. So it gives you a sense of how many are struggling. If I go into a class of 20 kids, I got 4 kids who are, really struggling. 5 kids, excuse me.
Yes. Well, so many. We've captured as many questions. I just want, a lot of people have asked about genetic testing. So if you want to quick cover kind of the genetic testing, what you use, what is that? That'll be our last question. I've captured everyone's questions. I'll circle around with Dr. Kotler to see how we can get those answered. Thank you all again so much for participating. Let's talk about genetic testing.
So the genetic test that I use is called Genomind, and that's G as in good, E-N-O, mind, M-I-N-D. And I use that company because they're just the best to date that offers the most information. There's other companies in the pipeline doing some exciting stuff. And also the company is located in King of Prussia, Pennsylvania, which wasn't far from where I was in Southern New Jersey. And the head PharmD there, Dan Dowd, is just unbelievably brilliant, intelligent. He's become a friend. And when I first started, the test became available in 2009. And it looks at 26 genes, and there are 16 genes that are involved in the genetic risks and trends toward depression, anxiety, response to medications, ADHD, mood disorders, and then there's about 9 genes involved in metabolism of medication and absorption of medications. And I will say that, you know, there is some controversy with genetic testing, and some people who sit in higher academic glass houses will put their noses down to it. And my patients, and Tiffany's heard me say this as well, as, you know, to that population, I say, this bus has left the station. Back to, I feel like we owe you every weapon we have in our arsenal, because years of doing it, even with my own child, both before and after, it was like, yep, that was why it made perfect sense. Like, why do we have to suffer through all the SSRIs, for example, the Prozac, Zoloft, Lexapro, when we know that you're hardwired not to do well on them? Why should we have to go there? Why do I have to put 2 drugs together that we know, well, one modifies the drug level of the other and jacks it up 6 to 8-fold, that I can predict what's going to happen before I write it, because those drugs don't play well in the sandbox, is how I describe it. Why do we have to suffer those pitfalls and setbacks? And even to understanding the risks of addiction are there as well. It's not everything. It's a launch pad. There's some screens I open and everything is normal. Okay, I have the metabolism and I know what's not there, which is, you know, again, invaluable. And I have to say, it always matches. I had a genetic review appointment this morning, and I said to the mother, this is why I didn't write for anything. I'm like, we can wait a couple more weeks. Let's get this, because to jump into the wrong area of medicines and create a mood disorder trying to treat one, or the band-aiding of medications, I can't stand. Like, if you're on a stimulant, I say, oh, let's give you some, you know, some clonidine, you know, to get you to go to sleep. Well, yeah, that drug can cause some sedation, but before you know it, that sedative fact wears off in a week or 2, and now you're left giving it every night. Now you're getting a blood level of that drug, and now you're contributing to more irritability, potentially worse anxiety. You brought another drug on board, and if your kid isn't sleeping, let's take steps back and realize, did we create the insomnia? Was it present before the stimulant? Like, you know, you don't want to create a problem trying to fix one. And if you have, one of my mentors years ago said to me, if you haven't created a mood disorder trying to treat one, you're not treating enough. And that's so true. I used to say, oh my God, I hate that happened. Like, you know, I hate that, you know, I gave you, you know, Prozac and your kid was manic and was up for 3 straight nights and was zam zooming all over the place. But I'm glad it did, because now I know which way to go. And, you know, I hate to have those dramatic reactions, because you don't get a second chance often, not just with parents, you know, because every patient I have 3. I have come with a parent and a father, particularly the younger ones. But teenagers don't give you a second chance. They'll give you one. And they're like, you suck, she sucks, that drug sucks, I'm done, I'm finished. So you can't, you know, have them walk off a cliff or have the train you. You've got to jump in very low, very slow, subtherapeutic, inch along, make yourself available, you know, stop it before, and the little hints and whiffs that you get that this isn't going to go well, and knowing how to recognize them and pull the plug before the train has derailed. And really peel apart. Some kids come to me on 6 medicines. I'm like, you're on more than somebody, you know, who's institutionalized. Like, this is crazy. Let's pull these off, because I don't know who you are. And which drug is doing the heavy lifting. Even if I have the genetics, I'm like, I don't know which medicine really is, like, which one can you not live without, what I call the brain glue. Like, I can live without everything. Take the ADHD drugs. I will not live without the mood stabilizers, because those are the brain glue drugs that allow your child, adult, teen to function in society, literally. You can deal with, believe me, some inattentiveness. And by the way, fun fact, a lot of the true neurochemical ADD does tend to burn off as time goes by. You know, the hyperness starts to really come down by late adolescence, but the higher neurocognitive functioning the executive functioning does not. So again, when you see those hyper, teenagers, or adults who can't sit through a conversation at dinner, you have to question, but it offers a lot of information and it gets you from, disease state to remission a lot faster. And knowing that I have to start, I have some patients on 60 milligrams of Lexapro. I'd never do that in a million years, unless I knew they were an ultra rapid metabolizer of the one enzyme that's responsible for breaking down that particular medication. So I'm not wasting time at 5, 10 milligrams. I'm starting at 20 and I'm going to 40 and I'm hanging out for a couple months and seeing, what our symptoms still are and can we benefit from sneaking up higher. But we wouldn't do those things unless we had the guidance to do it. So a lot of the trial and error time is reduced. It's really a benefit, a big tool, especially for the child with a complicated history, where there is just a lot of, mood disordered relatives, families not talking to each other, alcoholics, explosive tempers, walking on eggshells. I look for stability, right? One job, one life, educated. It really speaks to, can you launch? Can you sustain and maintain education and get through it? That speaks volumes. Can you maintain relationships? Spouse being one of them. And can you maintain a job without pissing off your boss every 2 years and having to leave because of your attitude and whatever? And dealing with constant unemployment and setbacks for the family, that's traumatic. So there's all kinds of clues and insight there. So if we can bypass some time and not cause more trauma, that's the goal.
What a great conversation. And thank you all for the wonderful comments, the questions, the feedback that we're receiving back. Appreciate it so much. I think, in so many people and so many of the questions we're talking about, going to professionals or pediatricians and providers that, aren't listening. One parent mentioned, her daughter had a massive panic attack right in front of there because of getting a shot, but yet the pediatrician's like, she doesn't have anxiety, so, I think, and you can address that as well, but it's as parents really using our gut instinct.
Yes, you said it. Trust your gut. Listen to the inner whisper. You are right. No one knows your child more than you do. Yeah. And if you're not being seen and heard and engaged, move on. Find someone who is listening. And there are even, there's some pediatricians who do have an interest in the behavioral. They might not know exactly what they're doing or how well to do it, but they'll recognize that there is an issue. They'll listen to you and they'll refer to some of their friends who get it a little bit better. And I just encourage you, because don't stop. You wouldn't with any other disease. If your child had some inoperable tumor, you'd fly all over the country. You'd be online researching, Googling. If there's a new therapy in Germany, you'd be off. And we have to get as aggressive for this as well. But most of, pediatricians included, who should be, somewhat developmental experts, don't understand what the face of all this looks like. And especially, I was a boy, I wrote, I can't stand that. She'll mature, this or that. I have just as many girls who act like the boys do, and that really upsets me. Oh, he's a boy, of course. No. I've just as many dysregulated female patients who are just as angry and violent and throw and break things and lose it as boys do. You just really have to push, and it's hard. There aren't enough of us out there. There just aren't. I struggle with the same. I couldn't get quality CBT when my son was younger in my area, and I deemed them all, worthless, because it was. And I was spinning my wheels at 5 years old in play therapy with a kid who would just lose it like it was a waste of time. So it's optimizing resources, which is my mantra. The other thing is these big expensive evaluations. Watch out for that, because they don't help me. You go to spend $3,000 to $7,000 depending where you live. And this is often what happens. Pediatrician says ADHD, or, gives you Vanderbilt scales or Connor scales. Parents, teachers fill them out. That doesn't help me either, because as I just spent my time talking about, a bipolar or hypomanic kid or anxious or depressed kid will take every box on those scales and walk, talk, and quack and meet the criteria. Where's it coming from? Pediatrician writes for several stimulants. They fail. Off to a big expensive evaluation you go. It comes back saying he's got some anxiety and ADHD, so we'll try this different stimulant, and you're still spinning in circles. And these evaluations, and again, I'm looking through it at it all through a different lens. I mean no disrespect to them, but they're what I call freeze frames in time. It doesn't rewind and watch the whole movie. And often a child's presenting for this test, by the time I get it and you get it back and I'm reviewing it, we're on whole different medications. The rules that applied for that test, and did your child, were they upset that morning? Did they eat enough? Did they sleep well? Did they like the person who interviewed them? Did they like where they were? Were they pissed that they were losing a day of fun, that they had to go for this testing? There's so many factors that factor into how they perform. Like, listen, when you get an IQ, this happened to me a couple weeks ago, child had an IQ of 78. I told the parent, don't get hysterical. Your kid's in 5th grade. They would have been pulled in preschool, in kindergarten, if their IQ was truly 78. They'd be struggling with reading, with math facts, with sight words. This IQ is much higher. And especially when you see inconsistencies within the reports, my radar goes up for mood disorder. They zoned in, they zoned out. They had a good day, they had a bad day. They'll score, above average and below average, depending on how they walked in, particularly when the testing goes on over 3 to 5 days, when it's in the academic, school setting, where the child study team is doing it. So there's so many factors, and parents don't even know how to read these reports. It takes someone to go through it with them, looking at it through the eyes of mood, academic, and the school, criteria and what those tests are and how valuable those specific tests are, what the limitations are, et cetera. I don't know if I answered that one, but.
Yes, that was wonderful. I will be sending out the recording. I'll circle back with Dr. Kotler on the questions. Thank you all so much. This was very popular. I think we should have you back very soon. I know there's a lot of questions people still having. So again, to all the participants, I so appreciate you joining. I so appreciate your support of Guiding Bright Minds. If you do have questions on your journey, if you are looking for professionals, you're looking to help, please reach out to me directly. There's a contact form. I put that on there. Some of you may have my email address. I should have put that on there as well, but you can email me directly. But here to help, here to walk through, and please reach out to Dr. Kotler and get a consultation. Amazing, as you can tell from her depth of knowledge and the passion she has and how much she cares.
I was going to say, Tiffany is a great resource. Everyone on her site really is all that. I will tell you, in being new to the area, it's been a great resource for myself as well. And I do also do telemedicine visits. I work with patients all over the country. I wouldn't have thought that you can connect via telemedicine until the pandemic, but I'll tell you that I have some really special relationships with some very special families and teens and children that I just got to hop on planes and go give them big hugs and see them, because I feel like I know them. There's such an intimacy. It's difficult to explain until you do it, because listen, when the pandemic started, I would tell patients, we'll do it, but I'll do it for free in my office if I don't feel like we bonded. And I meant it, because I was like, I can't take money from these people if I'm really not doing it, but I didn't have to do it. We really were able to come together, and it was big hugs and kisses. Like a year and a half later for some of them, we actually finally got to physically meet. So there are all different ways. There's no cookie cutter way, to go about this. It's just about finding, good people, and just keep talking, word of mouth, asking, networking, wherever you live, wherever you are. These people do exist that will listen, and we do collaborate, and communicate with each other in the community. So thank you again for your time. I appreciate it and I respect it.
All right. So much. Thank you, everyone. Good evening.